We made it. We're here live on Facebook.
It's the government, Ryan. It's the government.
Oh, man. Sorry for the wait, everybody. But we are here tonight with Dr. Brandon Brock, and we wanted to talk about everything that's happening in the world. And so I'm basically going to let Dr. Brock take over because he's done a ton of research on coronavirus, COVID-19, and he's here to drop some knowledge on us. So thanks so much, Dr. Brock.
Ryan, thanks for having me on. After that brutal effort to get on, I feel like I have the virus myself. To be honest with you, no insult to anybody that has it, but no, look, man, we're living in this weird time. You know, I was driving home today and I was like, we're living in this zombie apocalypse, but there's no zombies. There's just no people around and everybody's hiding out. And I think they're probably doing what the government, the World Health Organization, and everything is saying to do. But the bottom line is it's just a strange situation. I don't know how it is where you're at. How is it?
Yeah, I think like the one word I use to describe it is everything's just so weird right now.
It's if you're even a Gen Xer, especially a millennial, you've never seen anything like this. I mean, this is absolutely one of those things where it's just completely bizarre. So what I wanted to do is just talk about, if we can get on Facebook again, several get-togethers where we can talk about the epidemiology, the diagnostics, and the treatment. And that way there's some people that are educated on COVID. And so we can walk around, and as clinicians, and most of the people on here are clinicians, I think, even if not, it doesn't matter. You still need to be educated on it. And what do you need to be afraid of, and what do you not need to be afraid of? And the first thing I'll say is I'm not a virologist. I do practice medicine, and none of this stuff is made to treat, diagnose, or prevent anything. We're just here to educate. Okay, Ryan?
Deal.
So take it away, buddy. What do you have for me?
So what is it? What is coronavirus? I think we got to kind of start there, and then we'll move forward.
All right. So there's several things that have happened in history, and the first thing was SARS. Remember SARS?
Yes.
Ryan, are you actually old enough to remember SARS?
I am.
Okay, so SARS. All these things start out in bats, and I got to tell you, I've got a new fear of bats. So for some reason, there's a mutation of a virus from bats to civets, or cats, okay? And from cats to humans, and that made SARS. Now, there's this really interesting, I love statistics. It's just my favorite thing, okay? So there's this thing called a fatality ratio, or a case fatality. And so what you do is you take the number of people infected and you basically divide it into the number of people dead, and you end up getting a ratio or a percentage of dead people per people that tested positive. Does that make sense to you?
Yes.
It's just like calculating percentages. Okay. So back in the day when SARS, there was roughly 8,000 positives and about 800 died, and you end up getting about 10%. That's easy math. Okay. Now, who knows how many people were tested and had it, and how many people who were not tested? We really don't know if these numbers are correct. So I'm going through the coronaviruses right now. There's a lot of them. Give me the common ones. Now there's MERS. Now, by the way, SARS, okay? So it's sudden acute respiratory syndrome, right? And it was lethal. I mean, it was very lethal, okay? But it didn't make it really to America, so the media didn't pick up on it. And by the way, if I talk about something that fits into your conspiracy sort of thought, I'm not here to talk about conspiracy theories. I'm here to talk to you about what I think is going on right now, and you can drift off whichever direction you want. Now, there's something called MERS. Now, this is a very bizarre one to me. I got to tell you, I studied MERS, and this is Middle Eastern Respiratory Syndrome, okay? So this went from bat to camel to human. Now, I don't understand how we went from camel to human, but we did. And it had about 2,500 cases, about 850 fatalities, and it's about 3.4%. Okay. So anyway, I'm sorry, 34%. So we get up to the point to where we're getting a little bit higher. Now we get to corona or COVID. Now, the thing about COVID-19 is it's not really, it doesn't look exactly like a coronavirus. It looks like an unknown virus in the year 2019. So you can't really call it a coronavirus. So they call it COVID. So it's unknown 2019. It looks similar to a coronavirus. So they call it COVID. Okay. So as of the 15th, there was 5,735 deaths out of 1,500 or 153,517 for a total of 3.7% case fatality. Now, let me ask you a question real quick. What happens if that bottom number goes up? What happens to the case fatality?
It goes up?
Well, it goes down. Ryan, come on.
Sorry.
Are you smarter than a fifth grader?
No, not right now.
So as of 6:45 today, it's 246,073, and the death total is 10,161. So about a 4.12 death or case fatality. Now you got to understand something. These conditions scare people based upon case fatalities. How many people die? But the question really comes down to, what is that denominator? Because the bigger the denominator, the smaller the case fatality. And the smaller the case fatality, the less people care. All last week on Facebook, people were just looking at me like I was crazy. I wanted tests because I believe that there's a lot of asymptomatic 18 to 35 or 40-year-olds that just don't have any symptoms.
Yeah.
So there's a huge positive rate, but they're not symptomatic, but they're passing it to elderly people or people that are respiratory compromised. Okay. So those people end up going to the hospital with any condition, whether it be flu, whether it be whatever. Okay. So they're always prone. So in order to keep our number up to 4.12 or higher than the other coronaviruses, let's just test less people. Now, I understand that the technology is not as easy as everybody thinks it is, and there's a whole bunch of people jockeying for these tests. But in order really to understand this, like South Korea did this perfect. They tested everybody, young and old, right up front. Everybody that was young, they quarantined. They gave them the right distance. They were separating and all that stuff. And there was very little death. In places like Italy, they didn't test people until they were almost dead. And they said, oh my God, they got, COVID, and they were already almost gone. So they didn't find the carriers that were younger that were passing it on to the older people. So that denominator is a huge factor in this. If you don't test, you can't make this a national emergency. Do you understand that?
Yes.
You can make it a pandemic. I mean, lots of infections become pandemics. Well, I say that, but how virulent is it? How deadly is it? How dangerous is it? So now we get to the situation where we've got SARS, we got MERS, we got COVID-19, and what we have is the math, and the math can always be changed. Okay, so how many people were actually tested? How many tests were available? How many people were hospitalized? The people that die is pretty static, but the people that were tested is not static. And so the bigger that number is, the smaller the mortality rate, the less scared the population is. So I look at this and I say, okay, here's conspiracy theory number one. People would say it's overblown. Well, I would say maybe, maybe not. It is a very virulent disease. And I would say that depending on that denominator, it will determine the actual case fatality of the disease. And if the case fatality is low, it doesn't matter. I mean, worldwide. Of course, it matters to a family, but it doesn't matter worldwide. So just to give you an example, there's something called an R naught. And an R naught, to be really specific, is the reproductive ratio. So in other words, if I've got the disease, how many people am I going to give it to?
Right.
Okay, so that's the biggest deal. How contagious is this condition? We can calculate it by something called an R naught. Now, the R naught is calculated by a linear regression, where we go back and we look at the statistics and we say, okay, based upon what's happened, we can guesstimate what's going to happen in the future. All right, so just to give you an example, an R naught If I'm one person and I give it to another person, that's an R naught of 1. That's pretty low. I mean, that's pretty much common. If it's less than 1, we consider it really nothing. Okay? Do you understand the R naught?
Yes.
Okay, so the R naught of like SARS was 2.5. So for every one person that sneezed or did anything like that, they were probably going to get 2.5 people. So you got to quarantine people and get them under control before they get 2.5 people under, the same kind of symptomatology that they have. Okay. Now here's the interesting thing. The R naught for one person for COVID is 2 to 4. So we're thinking it's about 3 people. So one person turns to 3, 3 turns to 9, 9 turns to 27. You can do the exponential or the times 3 mechanisms or the equation to it. And so what it does is it equates to a massive spread. Now, one would have to say, where does the number of people contaminated come from? And it comes from previous statistics, and the previous statistics come from China and other places. So how reliable is it? That's always a question, right? Mm-hmm. And that's another conspiracy theory, right? So, but I believe it is a very contagious thing. But I will say this, in the ages of 20 to maybe 35, it's pretty much asymptomatic. So now we've got probably, and I've seen some very interesting statistics that show that out of 100 random people tested, about 60 to 70% of people test positive. They're passing it on, and it may get to an elderly person that has a respiratory illness or respiratory predisposition, and now they're getting infected and they're becoming the mortality morbidity factor, and it becomes lethal. But now you got people on spring break, they're partying it up, they're passing it around. The R naught is 3.5. Everybody coughs, sneezes, they spit on each other, and now we've got this thing spreading all around. It's no big deal to them. 1 or 2 of them will get really sick if they're immunocompromised or have leukemia or something else. But other than that, they get a little stuffy nose and they pass it off to everybody else. Yeah. Does everybody understand why the younger people don't want to be quarantined?
I mean, I understand why they don't want to be quarantined. It's unfortunate that they don't understand why they should be.
So those numbers are probably real. So an R naught is a reproductive ratio. How many people you're going to infect? The degree of spread. Flu, and everybody's trying to compare this to the flu. The flu is 1.3 R naught. This is probably 3, well, they're saying 2 to 4, but it's really 3 to 4. Some people saying up to 5.8 R naught. That means for every one person that has it, that's how many people are going to get it. So it's spreading very, very, very quickly. The flu, of course, is dangerous, and elderly people that have like respiratory illnesses, of course, are going to be compromised. But with coronavirus, it is a respiratory virus, and I'm going to explain that in a second. But it's very virulent. So that's the one thing. Now, there's something called a series interval. So I just explained to you the R naught, and the R naught is you, Ryan. If you get it, how many people are you going to give it to? So flu, maybe 1 to 1.3. With coronavirus or COVID-93, you're probably going to give it to anywhere from 2 to 5, depending on if you're quarantined or not. This is why they're trying to quarantine people. You may feel okay, but please don't go out.
Yeah.
All right. So this is why society shouldn't panic, but it's also why the terrible thing is the incubation phase can be up to 20 days.
Yeah.
So I'm going to get into that in just a second. So when you get to the series interval, so that is the time that it really takes, like if you're looking at, say, 14 days is the entire run of the disease. Okay. So you have the first person, and let's say that out of the 14 days, it starts on day 2, and then they transmit it to the next person, it goes to day 5. So there's a 3-day series interval. COVID has a 5.7 series interval, but the flu has a 2.5. So what that means is you will know you have the flu faster than you will COVID. So what happens is people are like, I got the flu, I got to stay inside, don't get around me. But it's got a very low what? R naught. Okay? Whereas COVID has a very high R naught, but then it has a very long series interval. So what's happening is people are going for days, asymptomatic but have the condition but are giving it to X2 or the next person.
Yeah.
So you're starting to see the contagion or how contagious this is, but it's not really for the average person that fatal. Some people are saying I've got allergies, but it's not. Some people are saying I have flu-like symptoms, but it's not. It's this. So day one was probably November 17th. So just to let you know, SARS probably bat to cat, okay? MERS probably bat to camel. COVID, if it's not, here's another theory or another, conspiracy theory. If it's not a conspiracy theory, it's probably bat to pangolin. And a pangolin is a little thing that looks like an armadillo. And they think that the actual scales on a pangolin have medicinal powers. This is what the Chinese think. And so they send these things all over the world for medicinal purposes, and they think that it might have spread that way because it's in a pangolin. Okay, very bizarre. All right, so now we have bat to pangolin to a very high R naught, to a very long incubation period, to a very long series interval. And this is why you see people on TV and they're like, you need to stay inside and quarantine yourself for like a week because it's about a 5.7 day series interval. And they want you to stay inside 7 days because you might show symptoms during that time period and then not go out. But if you go out before then and you cough and sneeze, it goes to 3 to 5 other people.
Yeah.
So this is the epidemiology behind this. And so people are freaking out because they're like, oh my God, we got to be quarantined. But what's really happening is it's not that they really want to quarantine asymptomatic carriers. They just don't want the elderly people to die because they're trying to flatten out that curve. Now, there's two things. If you spread this out, you flatten out the infectious curve. So not all the people are on respirators at the same time. Okay. But then there's some people that think that you should just let everybody get it at once and let the curve go up and burn it out very quickly. And I got to tell you, the only group that has done this right is South Korea. If you look at South Korea versus Italy, they destroyed it because they tested everybody up front. We are just now getting rapid tests. Okay. So if you can't, me and you could, either one of us could have, COVID.
Right.
And we don't have it, but we're seeing our patients and, it's transferred via fecal oral route or respiratory route. So, all it takes is you to fly to Hawaii, go use the bathroom. Somebody from Asia goes into the bathroom, uses the bathroom, doesn't wash their hands, touches the doorknob. Your wife touches the doorknob, comes out. 10 days later, she has a cough for 3 weeks and feels like she has the flu, but tests negative. True story. Are you understanding?
Yes.
So
Crazy.
we think this has been around longer than we think. We don't know. For those of you that think it's engineered, think that. For those of you that never heard of a pangolin, go look it up. These COVID viruses, there's a lot of them. I just gave you several of them, and I gave you some numbers, and I gave you the up-to-date numbers as of 6:45 today. Now, if we tested everybody, the denominator would go up so high, the mortality rate would be fairly low, and the fatality or the case fatality would be so low that there's no way we could make this oh my God, we're all gonna die kind of thing.
Yeah.
Now, I would just want to say something. I feel extremely sorry for people who have lost loved ones. I'm not trying to make light of that. But what I'm trying to say is per population, what's happening is if you look at this, the fact that we're closing restaurants and we're closing bars and the economy is getting destroyed over something that I think could be artificially manipulated. No tests, no denominator, an abnormal case fatality number. If the case fatality number is not that big, what are you going to do? It's just like anything else. If you look at the top, 50 killers, it's like number 35 on the list. It's way down at the bottom. So when you look at this, you kind of start thinking, man, the media can take statistics and statistics can be manipulated and it can all be changed. And now we have something that now turns into a pandemic and everybody's going to die whenever they're really not. So what I'm saying is, yes, stay quarantined so you don't get your elderly neighbor sick, but maybe we should be testing more people so that we really know who's infectious, even if they don't know it. That is my thing for epidemiology, okay? That's what I figured out, working through it the last kind of 3 days and kind of looking at it as, for what it is. So we know this is fecal oral route. We know it's also respiration. COVID, we know that there's a 3 to 6 feet, spread. Now, it can live on a surface for 24 hours. So look, for all those people that are in clinics trying to be sanitary, this stuff is living for 24 hours. Unless you wipe down everything completely, you wear the appropriate mask, not a surgical mask, okay? And when you use gloves, if you touch something and contaminate yourself, the gloves are just like your hands. Realistically speaking, this is a very difficult thing to do. As a matter of fact, it's almost impossible. The second you touch your pen, you've contaminated yourself. The second you touch the file, if somebody else touched it, you possibly contaminated yourself. Because this stuff lives on a surface for 24 hours. It's airborne for up to 2 to 4 hours, which, by the way, is very unusual. So if this was made, it was made to be durable. And the durability equals the R naught. So in other words, it can be passed. If the durability is very, very low, it's just going to die when it hits the air. When it hits the surface, it's going to die very quickly. And so not many people are going to get it. Okay. So I'm trying to explain the hysteria behind this. Okay. So anyway, let's say that you do all this stuff and you get it. And so tonight I just want to do part 1 and explain why in the world you get this and why are some of the drugs used. And then if anybody wants it, we can do a part 2, which talks about the treatment, and a part 3, which talks about the diagnostics, which by the way, I think the diagnostics are fascinating because there's some actual vitals that you can look at that are critical that might tell you that this is there before a fever. Okay. So anyway, you swallow this stuff down. So it goes into your mucous membranes. Now, these viruses don't live very well in hot temperatures, which is why we have a cold season. Okay. So one of the few things I do when I come home is I do sort of a steam up into my nostrils at about 138 degrees. Most of these things denature and they fall apart. Okay. Now my wife loves to give me essential oils and all that kind of stuff. So I use them.
But I thought I could smell you over here.
Yeah, exactly. I smell like eucalyptus, man.
So for people, well, are you saying so if people are out and about and they come home, do a little bit of a steam, breathe?
Yeah. So I've got a contamination room or a decontamination room. I come in from my garage, just a little utility room. I wash my hands really good. I take my shoes off because shoes are dirty. I've got scrubs over my regular clothes. I take my scrubs off. I put them right into the washing machine, start washing them. And then I clean everything off really good, with Hibiclens. Yeah. And then I just come in and there you go. Okay. So that's kind of what we do. And then, we are kind of quarantining, meaning we're not going out to eat. We're not running around and stuff like that. We're kind of trying to be responsible. I mean, I know the R naught on this, and I don't want to get my neighbors sick, and I don't want to get the elderly people down, the street sick and stuff like that. Okay. Yeah. So we do that. All right. Now, by the way, little kids, very few people get it. Now, there's been some cases of some kids get it, but one had leukemia, another one had asthma. I mean, they had other conditions. Yeah. And God love them, man. I mean, that's terrible. Okay. So what happens is you swallow this down, it goes into your mucosa, and you end up getting it down into your respiratory system. Now, if you have good IgA, and I'll go to the treatment and I'll talk about SIG-A immediately, but I'm not going to talk about it right now, but SIG-A nails it in most people, as well as natural killer cells. And what can you do nutritionally to help with SIG-A and natural killer cells and mucosal membrane immunological function? But let's say that's not that great. So you swallow it down, it goes right to an alveoli. So your alveolar the little sacs, they contain two cells. They contain these pneumocytes. Type 2 makes surfactant, and type 1 deals with gas exchange. Okay? So these sneaky little COVID viruses, they go down and they attach to type 2 receptors. Okay? And the interesting thing is there's a little thing, if you look at the ball on that, there's a, most people have seen a picture of it by now. It's a ball with a little bunch of little spikes on it. It's got an S spike on it. Okay. Now that S spike does something very interesting. It attaches onto type 2. Now, type 2 is your angiotensin converting enzyme receptors. You know what that is, right?
Yeah.
Dealing with renin. So it attaches onto that. So big deal with gas exchange, right? Because gas exchange is type 1. However, right then and there, the actual virus cleaves and then goes into another cell and it drops its RNA into another cell. Now, France has declared they have a cure for this, and it's Zithromax with an anti-malarial drug, a hydroxy, quinine.
Yeah, I saw that.
Hydroxyquinine or Plaquenil, and I'll explain that in a minute. But Zithromax stops translational RNA, which is very interesting. It stops the translational RNA in the cell. So when it goes into the cell, the RNA goes in and it goes to the ribosome, and it hits the ribosome, and you make more RNA, and then you make more proteins, and those proteins and that RNA come together, and guess what you make? More virus. Boom, it's shed outside the cell. You get an RNA-dependent polymerase. It binds with a single strand and to these proteins, and you end up getting all of this expulsion of more virus, okay? So that single-stranded RNA turns into a combination with a polyprotein, and now we have all hell breaking loose. And these enzymes that make this is called a protolase or a protease. Okay, proteinases. So when you do this, these type 2 pneumocytes, they become damaged. So now they're damaged, and what happens is these type 2 are destroyed, and as a result of the inflammatory response, macrophages start coming into the alveoli because they're like, hey, wait a minute, something's going on. There's an infection in here, okay? Mm-hmm. So when something comes into the alveoli, we have the infiltration of neutrophils and macrophages to come kill it. Makes sense, right? Let's kill this. Yep. Now, I had this very bizarre, like, what in the heck is going on here? Kind of, like, why would they give Plaquenil, an immunosuppressant and a cytokine suppressant, to somebody with this disease and it cures it? So check this out. When the neutrophils and the macrophages come in, they make so many reactive oxygen species, it kills the type 1 pneumocytes, and now you lose gas exchange. So now you start to suffocate, dude. And as the cytokines go out, you get basically the capillary beds become porous. So the albumin leaks out, so it goes out in the interstitial fluid, and it basically, the fluid goes in the alveoli, it dilutes the surfactant, and then it compresses on the outside, and the alveoli crush in, and you don't have gas exchange. So here's the thing, man. You have a cytokine barrage. Th17 comes in to control Th1. So picture this. Remember MC Hammer?
Can't touch this.
Can't touch this. He had his posse. So the cytokines come in. Th17 comes in and says, we're going to regulate. But Th17 causes also damage to mucosal immunity. But it also regulates Th1. So this is a major Th1 response into the alveoli. When it comes in, you make massive reactive oxygen species. This is why some of the treatment that I'm going to talk about next time may work in conjunction with something that now we know why an immunosuppressant that stops the white blood cell count, and after those white blood cells are made, you blast out cytokines. Interleukin 1B and interleukin 6 go flying out of the alveoli. You follow me?
Yeah.
And they go and they cause things like this. You ready? Vasodilation. Now you don't get any blood to the kidney. It shuts down. No blood to the liver. It shuts down. And you get septic shock. And that's when people die. So that's why they're saying if you can stop the cytokines, you can actually make this not have a cytokine barrage. And if you can stop the translational RNA with Zithromax, you can stop it from replicating. That's why these French scientists are saying they have a cure. It's not killing a virus. It's stopping the step-by-step process that's occurring, okay? Now let's talk about this for a second. So anytime I say cytokines, we say vasodilation. Now plasma leaks. It compresses like I told you. It does everything I talked to you about. Now it goes to the liver, and what goes up whenever the liver gets damaged? The interleukins activate hepcidins, and your acute phase reactants go up. Now here's the thing, guys. By the time your acute phase reactants have gone up, you've already created a consolidation in that alveoli, and that's what you cough up and infect everybody with. It's already too late. Those cytokines go into the brain, they activate the hypothalamus. Guess what they cause? A fever. But now there's new literature out, which I'll talk about later, where these viruses infect the brainstem and alter the respiratory and cardiac centers. So now here's something you need to all watch out for. Before a fever, you have blood pressure that's lower than normal, vasodilation, heart rate that goes up to compensate. And now what happens whenever you crush those alveoli? What happens to the ability for you to breathe?
Not good.
You're trying harder. Elderly people can't keep up. They got to be ventilated. So if you're dyspneic, if your blood pressure is low and your heart rate is high, be concerned because the temperature's coming. It just hasn't hit the hypothalamus yet.
Yeah.
So what I'm trying to do is give people a way to do vitals, and somebody doesn't have to be near dead before they find out, like, man, maybe I should do something about this. Now, what's interesting is there's a nutritional component for every single step of this. And this is why people that are nutritionally healthy, they don't get it or they don't have symptoms. But God forbid I say this right now without explaining the pathophysiology. Drones will circulate my house and I'll probably shot down by magic lasers. Okay, so we've got the capillary permeability. We've got the fluid entering the alveoli. We've got all the cells coming in. We've got the consolidation. We've got the interleukins coming out. We've got the vasodilation. Now the kidneys suffer. The BUN goes up. The creatinine goes up. The liver suffers. The AST, the ALT, the bilirubin goes up. Now my acute phase reactants go up. And if it goes on long enough, you go into septic shock and you're gone. This is why they have said if there's a cytokine barrage and it hits all these other organs and it causes septic shock, you're done. Because then the ventilator doesn't work anymore. It's not about the ventilator anymore. Now it's about the septic shock. Okay? So I was wondering, I was like, man, ventilator. Well, it's beyond ventilator. It's now septic shock. Now, how many nutrients lower inflammatory cytokines and regulate Th17? This is why vitamin D is so important. So, I mean, I'm going to go on with nutrition, assuming that this doesn't get pulled.
Tonight?
Yeah, whenever. So, what I'm trying to tell you, Ryan, is that this is a very serious condition in people where it is allowed to be serious. In people who are healthy, this is a condition that is just an everyday exposure kind of thing and not that big of a deal. The point to my story is that everybody understand the statistics and how they can be manipulated a little bit to kind of maybe perpetuate a story of one thing or another. And I'm not saying that you should or shouldn't quarantine yourself, because I really think people should, because really normal people don't know if they're infected.
Right.
Okay. And remember, they are not. But I also want to say that there's a lot of things that people can do nutritionally so that they don't get infected with this or they don't get sick from this in the first place. And maybe we don't need to get to these medications, or maybe we don't need to get ventilated, or maybe you can keep people away from your neighbor's house where they're 85 years old and they have emphysema and COPD and you're watching out for them.
Yeah.
That's what I think that needs to happen. I've been weighing this out. Like, should we quarantine? Should we not quarantine? Is this serious? Is it not serious? It's all of it.
Yeah.
Where did it come from? I don't know, and neither do you. They say it's a pangolin, or from what I read. Was it engineered? Well, there's been some people arrested. Read the media, read the Washington Post. I don't know if that means anything or not. I'm not in the government at the level of biological warfare. But I think this proves one thing. If there is biological warfare, it doesn't work because it kills everybody, or it hurts everybody, or it impacts everybody. And I got to tell you, this is a very low virulent disease compared to some of the other things that have been made. This is just a respiratory illness that only affects the elderly. What if it affected everybody?
Can you just talk about, I mean, because there have been, I know you mentioned young, like adolescents who do have comorbidities, but so you're saying definitely elderly. And then when they say flatten the curve, like, can you just explain to people what that means and
So
why that's
flatten the curves mean we do societal separation so that people don't infect each other.
right?
Here's the problem with that. So there's a lot of people that agree and don't agree with that. And so I'm going to give both sides of every equation because I'm not going to tell you what I believe. But if you flatten that curve, it lasts the disease lasts longer, which means the quarantine lasts longer, which means businesses shut down longer, which means society breaks down longer, which means the stock market goes down longer, which means you and I and everybody else suffers longer from an economical point of view. Okay? If we let everybody get infected and it spikes up quickly and then comes down, it comes down faster. Maybe the economy rebounds faster, people go out faster, but people die more.
Yeah.
Like in Italy. So in South Korea, they had it nice and flat. In Italy, they had it nice and high. Which one's worse? Which one's better? I don't know. It depends on what your value is on the economy and what your value is on human life. That is an ethical question that only you can answer to yourself. Okay? Because a lot of people would say, well, human life is worth way more than any of this. Well, I would say, well, what about the people that go into poverty? What about people that go into bankrupt? What about kids that starve to death? Is the government going to take care of it? I mean, there's a million ways you could go. Are we getting prepared for a socialistic society? I don't know. But the bottom line is this. It is what it is. So this is the pathophysiology of this condition. Now we lead to what is a medical practitioner going to do and what is a functional medicine practitioner going to do to help their people, the functional medicine people, prevent potentially and then treat as a medical provider potentially to keep people away from respirators. Because I did the math and I did the statistics on this. And if the R naught is right, and if you look at the age category and you break it down and the percentage of people that go in the ICU that will need to be on a ventilator, we don't have enough.
Yeah.
We don't have enough ventilators. Have you worked in a hospital, Ryan?
Yeah.
Have you seen a ventilator?
No, I mean, yeah, they're crazy. It's crazy.
Okay. How many ventilators are typically in a big hospital?
Not enough.
Okay. So do you think there's 150,000 ventilators in this country?
No.
I would question that. So you have to, everybody has to look at this in terms of what they believe in. I mean, do they think the numbers are real? If they are real, should this curve flatten by quarantine? Should it spike by going out? And my thing is this, I follow the World Health Organization because I don't want to get slayed.
Yeah.
You know, and I also don't want this. I got some neighbors that are in their 80s and I love them. I don't want them getting infected. I would do anything. I would rather be infected than them. They will have a very tough time. So kids with asthma, elderly people with COPD, elderly people with emphysema, anybody with immunosuppression. Now, what happens to people with an autoimmune disease? What are they making?
Inflammatory cytokines.
Inflammatory cytokines, which is exactly what this condition makes.
What about, I mean, autoimmunity for sure. We have a lot of brain injury, followers on the page. If you ever suffered brain injury, where does that put you at?
Okay, I'm going to speak into my microphone very carefully. If you've had a brain injury, tune in to the next brain chat. Because I'm going to take all these cytokines, Ryan, and go to the brain.
Okay.
And there's not enough time, really. But they're thinking this. Yes, that respiratory suppression happens in the alveolar sac, but they're also thinking that it happens in the central nervous system.
Yeah.
So we got to get to that. But I don't think we can get there by telling this gigantic story and telling 30 steps. I just want everybody to understand the initial steps, what an R naught value is, and what some of the other values are, what fatality means, how this stuff is calculated, how it can be manipulated, and then you make up your own mind.
Yeah.
I think people should be able to make up their own minds. Do you have somebody with a machine gun standing at your door? Maybe you're not making up your own mind. Should we self-quarantine? Here's my thing. Unless you know you have it, maybe you should. People are like this. This thing's no big deal. This is a very virulent disease. If the math is right, which I think the CDC got it right, and the R naught is anywhere from 2 to 4, this thing, well, I'll give you a story. One of our neuromates gave me a story where they tested 100 people just randomly and 70 people had it. If that's the case, maybe your sinusitis was COVID.
Yeah.
Maybe your allergies was COVID. Maybe your flu was COVID. I don't know. This stuff's been around probably since early November. So we don't know. I really don't think we know. We're not testing normal people, so that denominator is not real. I'm convinced of that. I am convinced of the fact the numerator is real, the denominator is not real. So anyway, enough of that. But this is the process that's going on. And so what we got to do is we have to start infusing nutrition into this story. And by the way, nutrition is not used to treat disease. Nutrition is used to amplify or augment physiology so you don't get sick. So there's not a diagnosis here. There's this. Let's make you healthy so you don't get sick.
Yep.
And I think the people that do that will probably have the best outcome of this, and it won't be as big of a deal. You don't got to walk around in a spacesuit, maybe.
Yeah.
If this was Ebola, it'd be a completely different story. But this is a respiratory type of syndrome. So anyway, Ryan, this is my part one talk. I'm already probably talking too long. I hope that people are starting to understand a little bit about where you see people from the CDC, they're talking about numbers, they're talking about quarantining this and that and the other. Where does it come from? This is where it comes from.
That's great. Thank you.
Does anybody have any, or can you see questions from the group?
Let me log up. People, I mean, this has been really great. And sorry again, everybody, that we were so late.
Yeah, and by the way, guys, this is my opinion, okay? I am not an epidemiologist with the NIH, but I've looked at this pretty close as a practitioner, and I can tell you that this is pretty accurate.
There's 62 comments, so I will read one of the most recent ones. So when do we, can we do a quick recap for all the new listeners, and then when can they expect part 2?
Well, you can expect part 2 whenever you, Ryan, the Brain Chat Maestro, says part 2. And there's going to be a part 3 also, probably.
Okay.
Because we could ramble on all day. But I think that, look, this is a big deal because this is every day for us right now.
Yeah, this is really bad. So we'll just keep the discussion going. Yeah, I think so. Yeah, that's one of the big questions. And then the other was, can you give a recap for everyone that's just joining in, because we have some people just joining in,
Just
and
rewatch it.
yeah, we'll do. There's so many things coming out. We'll do part two. All right, what are you doing tomorrow night, Dr. Brock? You want to have a
Do you
Friday night
work for the
date?
government?
What? You want to have a date tomorrow night on Zoom?
Maybe, dude. I don't know. Whatever, man. Whatever you want.
We need to check with our wives.
Probably.
But we will do a part two very, very soon. And then can you just give a quick recap for everybody jumping in, just touching on what it is, where it comes from, a little bit about the R naught, and then we'll wrap it up.
Yeah. Okay. So bats, they tend to be bad creatures. For some reason, bats get the blame for coronas. Okay. Corona to pangolin. Pangolin has scales. Scales are medicinal. They go all over the world, and this thing has been spread. It was in Wuhan. People say don't use the word Chinese. Well, that's where it started. Okay. So there you go. Now, should I call it a Chinese virus? I mean, whatever. Okay, I don't care. That's where the first case was that we know of. This thing has an R naught of one person infecting four, maybe 2 to 4 people. Flu 1.3. Flu very quickly. You know you got it. Get away. This, you don't know you got it. You're going to give it to a ton of people. It spreads exponentially. You go from 1 to 3 to 9 to 27, and from 27, you can exponentially go out, and pretty soon you've got hundreds of thousands of people. And for those of you that don't think that that's happening, it is.
Yeah.
The problem is most of the people out running around partying, getting close, are 20 to 45 years old. You don't see 87-year-old and 77-year-old people out at a club dancing next to each other. It doesn't happen. So, but those younger people give it to their grandparents when they go visit on a weekend. So they're trying to separate all that. It goes down to the alveolar sac. It attaches to type 2 pneumocytes. These are angiotensin receptor 2 enzymes. It goes through. It's an RNA. It goes into the cell on the other side. RNA now replicates because of the ribosome. It makes other proteins. It binds together. It ejects out other cells. It goes back into the alveoli, goes systemic, and the alveoli fills up with macrophiles and neutrophagi, and becomes Th17 and interleukins. This thing crashes. It collapses. The alveolar type 1 cells, they now shut down. Now gas exchange is not going through. The person's like, and now they're put on a ventilator. And then now you have a major cytokine surge, and it goes out and it puts you into septic shock, and your kidneys fail and your liver fail, and you die. So that's why the Plaquenil works. The Plaquenil suppresses the white blood cells. They don't go in and make reactive oxygen species, and it stops the cytokines. Yeah. Okay? The macrolides, which is the Zithromax, it stops the translational or the tRNA, so you don't make it in the first place. So you stop the reproduction, and then you stop the cytokine surge. Now, what could you do nutritionally around that to make it even better?
You talked about vitamin D.
We're going to talk about a lot of vitamins, dude. Not tonight. But what I'm saying is that very few people understand what a coronavirus is. Now, I want to tell you something else. The people that look at this, they say it looks like a coronavirus, but it doesn't.
It's crazy. So, and a lot of these symptoms too, they can pop up before fever.
Listen, by the time you have if you're screening for fevers, somebody's already screwed. That means they've already been infiltrated. There's already been alveolar sac boom. There's already been coughing, blowing out all this stuff. They've already gone probably into making cytokines, and they're going into the possible septic phase. Mm-hmm. Now you would check their kidney function, their liver enzymes, and everything else. I mean, listen, that's why I told you check for if your blood pressure's down and your heart rate's up and your respiration's up. That's not a normal thing, man. Like if you see that before these other symptoms begin, you need to start questioning that person. Yep. And I'm not telling people to get paranoid, but start thinking. My biggest thing as a clinician is this. Every condition that you're worried about, think about the physiology, think about the lineage of that physiology, and off that lineage, think about where are the symptoms. And if you have this symptom but not the others, maybe it's back here, maybe it's not. But if you have 1, 2, 3, and you got all 3 of them in a row, maybe you can say you're right here on this. The end stage is this: you're on a ventilator. Everybody can figure that one out. But my question is also this. My thing is, everybody wants to pour money into rebuilding the economy. How about pouring some money into testing people?
Yeah.
That's my biggest thing. So, and believe me, here's the other problem. The testing has a false positive, false negative rate that's anywhere from 3 to 7%. Now, when you're testing millions of people, that can turn out to be quite a big percentage of problems. But I still think it's worth it. Okay, so Ryan, I've taken up too much of your time. I love studying about this because I'm in it every day. And so is everybody else. And I think there's a lot of people confused. There's people that are scared because of what the media says. There's people that says this is stupid because they don't believe it does anything because they're young and they don't get sick. There's people that don't understand social distancing because they're like, this is crazy. They're just trying to destroy our economy. What I want you to do is take this story and then you yourself figure out, based upon this story, what you think is real. And then start reading some papers, start reading a little bit, start applying a little bit, and then you make your own decisions. I mean, if you think you're sick, do you really need to go up next to a 75-year-old and say, hi, how's it going?
Yeah.
I mean, I would probably say no. But do we need to destroy the economy? It's a whole nother question. Think about the leaders. They're in a very bizarre situation right now where they've got to err on the side of caution, because if they don't and things go bad, then they're just bad.
For sure.
So anyway, I know, Ryan, you probably got a lot of questions. I knew this was going to be a fairly hot topic. I want to come back on and talk about some of the nutrition.
No, yeah, thank you. I mean, I really learned a lot. Like I've had just a difficult time processing all this. It's just really weird, and virology is not my cup of tea. So,
Well, and in all disclaimers, I'm not very good at looking at electron microscopy or anything else and determining one virus from another. I'm just telling you the pathophysiology from a family medicine practitioner perspective.
Yeah, no.
I mean, that's all I'm doing.
No, I mean, it's amazing though, looking at it in that light.
Every family medicine practitioner that doesn't understand this or know this needs to listen.
Yeah.
And so people who are wondering, should I shut my practice down? Well, my thing is this: can you prevent this from happening in your practice? And if they say, no, I can't, then I'm like, you need to make the decision.
Yeah.
So listen, I love everybody that listened. This is really, I mean, I've dug and dug and dug for all of this information, especially the information that talks about Th17 and the brain and the nuclei, they get infected, and then taking it a step further and learning how to diagnose it, and then putting it all together into sort of a package and saying, here is your coronaviruses. Because guess what? There will be a reemergence, I promise you, of H1N1. There will be a reemergence of bird flu or swine flu. I guarantee you. So whenever it comes time, I'll explain those also.
Awesome. Well, thank you so much for your time, and thanks everyone for tuning in. We'll make sure to get part 2 appears as soon as possible, maybe a day or two. We'll check with our wives and make sure. But we are thinking of everyone, and I know we're all socially isolated, but please connect with us if you need anything, and we appreciate everybody's time. So
yeah, and maybe, Ryan, if we all get really locked down, we should just do a constant brain chat.
I have a 2-year-old, so he'll be in the background doing something. But
I don't think people would care at that point.
Oh man. But yeah, we're thinking of everybody, and everybody just be safe. And Dr. Brock, thank you. Always learning from you, man. You're amazing. I'm always like, how do you know this stuff, man?
No, man. Hey, look, Ryan, stop. I just want to say this about Ryan. Ryan is the heartbeat of Brain Chat. I want you guys to know that. This guy digs up stuff every day and puts it on there for your that little almost like coffee drink entertainment is what I call it, where you just read it and you're like, bam. And Ryan is very, very good at that. I mean, several of us work on Brain Chat, but Ryan really does that very well. And without Ryan doing that on Brain Chat would not be successful. I mean, I barely come on here. I just barely do anything. I just wanted to make sure that this information was out so that people can understand it, because I think there's so much confusion about it. And by the way, this could change in a week, these statistics, okay? When you look at the stats on this, they are changing so rapidly that you can barely keep up with them with a supercomputer. So it's really interesting. But I just want to thank the Brain Chat crowd. Share Brain Chat.
Yeah.
Share this. Bring people in. And I'm not just saying that because we want to make Brain Chat bigger. Brain Chat's fine. But bring people in so that they can just see it's not just about brain, it's about a whole load of other things. So if you can do that, that would be amazing by sharing it. And so I'll just advertise it, Ryan. There you go, man.
Thanks, man. They probably won't do it though unless we make sure we do a part 2. Everyone will be really mad at us.
If we do a part 2 and you don't share it, we're gonna find you.
No, we'll do a part 2. I'll post it once we get our schedules figured out. And again, thank you so much, Dr. Brock, and thanks everybody for tuning in. Dr. Brock, hang tight, and everyone have a good night. Get some good rest.
Be safe, everybody. See you.